The Psychedelic Report.
Psychedelic drugs
have played their part in America's long, strange trip toward an understanding of mind-altering drugs.
The psychedelic news.
Leading physicians, scientists, and experts share their wisdom about psychedelic medicines and healing.
50 years ago, psychedelic drugs were at the center of America's counterculture.
The brightest minds in psychedelic medicine. The Psychedelic Report.
We use the ketamine-assisted psychotherapy model that happens to have psychedelic effects that were not predicted when the drug was first developed.
From researchers to investors.
I think the biggest mistake we've made as a culture is the war on drugs.
To physicians to shamans and nonprofit pioneers.
Psychedelic drugs.
Recent research suggests some of them could have legitimate uses.
The psychedelic news
brings you diverse perspectives from the front lines of this exciting movement. The Psychedelic Report.
The Psychedelic Report was brought to you by Apollo Neuroscience and produced by Future Medicine Media. Welcome to the Psychedelic Report, your single source of truth for the psychedelic news. I'm your host, Dr. Dave Rabin. I'm a neuroscientist and psychiatrist trained in ketamine-assisted psychotherapy as well as MDMA-assisted therapy. Welcome, everyone, for another week of the latest and greatest going on in the psychedelic space, and to have some of the world's leading experts on psychedelic medicine and research to join us to share their wisdom with you all. We have two very special guests here today who are working on a study that's one of the first of its kind, along with a couple other folks that are going to be joining us in a couple weeks. Ismail Santos-Brault and Paul Stamets, I think, are collaborators on this study with you guys. But today we have two of the investigators of this study, which is called Microdose.me, which is one of, from what I know of, and correct me if I'm wrong, it's one of the world's largest studies in the real world of people microdosing psychedelics according to different protocols. And we have Dr. Pamela Kryskow joining us, who is a medical doctor, a founding member of the Canadian Psychedelic Association. She is a medical lead on the Roots to Thrive psychedelic assisted therapy program, as well as a clinical instructor at the University of British Columbia, which I've spent quite a bit of time at, living formerly in Vancouver, and it's a beautiful, wonderful place to work, and has multiple protocols in progress with psilocybin, MDMA, and ketamine. We are joined as well by Dr. Zach Walsh, who is a professor in the University of British Columbia Department of Psychology. He is a clinical psychologist with specialties in alcohol and addiction studies, and he has been doing research over the years that has been supported by a number of really interesting organizations that clearly shows the recognition of the importance of this work, from the Canadian Institute of Health Research and the Social Sciences and Humanities Research Council to Health Canada, BC Interior Health Authority, and many others. And Zach is the principal investigator of the Microdose.me study and also sits on the advisory board of MAPS, the Multidisciplinary Association for Psychedelic Studies. And we are very, very excited and humbled to have both you, Zach, and Pam joining us. So thank you so much for the time today.
Honored to be here. Thank you for having us.
Likewise, it's a real pleasure.
We'd love to start out, and either of you can jump on this to start, but we always like to start out learning about how you got into the space. Both of you seem to have a very strong background in Western medical training or Western psychology training. Could you tell us a little bit about how you found interest originally in the psychedelic world and what got you into this?
Sure. So psychedelics found me quite young at 15, psilocybin mushrooms, and they had just been integrated into my life here and there as needed as I grew up. I went through a criminology degree and fully understood the war on drugs and prohibition and where that came from. And prior to getting into medicine, I was a city firefighter for 8 years. And there came this realization, I don't know, I'm guessing like 5 to 7 years ago, that it was this experience with psychedelic medicine that kept me so healthy as I left the fire service and went into medicine, that I actually came out quite healthy. I mean, I've got lots of growth to do, but I felt pretty good. And about somewhere in the last 5 to 7 years, I really realized, I just, had this aha moment that clearly this belonged back in medicine. And that should have been blatantly obvious given my criminology degree. And I had been following all the research that was going on with Johns Hopkins and NYU. But sometimes, you don't put two and two together. And then when it came together, I did everything I could to figure out how I could bring that back into medicine in a way that was thoughtful and with high integrity. And in my work as a chronic pain physician, I knew that 50% of the pain that my patients are feeling was, existential pain, and that there was nothing that what I had been taught in medical school and residency could help. So there just became an aha moment. And then from there, how psychedelics are, they just steamroller you in. And before you know it, you're working on clinical trials.
Funny you should go back to 15 years old. I think that's probably when I first had my introduction to psychedelics as well. Before, going to university or any of that, that was really a real rite of passage, helped me understand who I was and what I wanted to do in the world. And I was involved in social justice movements throughout, late high school and early university, and also a musician. I did Dead Tour late in the day. I date myself a little bit with that, but psychedelics were really a big part of who I was before I became involved in health research and health services. And I have to say, when I started out, I wasn't sure if I was going to be able to integrate those parts, if that was going to be something that was personal to me and part of my journey, but whether that was going to be part of my professional life, the pathway just didn't seem as open at the time. In grad school, I was in Chicago working in jails and in criminal justice as well. So Pam and I didn't hang out then. I think we met about maybe less than 5 years ago, but a lot of similarities. So yeah, I was working in jails. I was really offended by the war on drugs and trying to find ways to integrate clinical psychology and that science and policy work around stopping the war on drugs. And then when I got my job at UBC, the medical cannabis movement was really gaining a lot of steam. It was around 2009, 2010. And so I transitioned from doing criminal justice-oriented work to really working in medical cannabis, both as an alternative treatment for mental health and also from a policy perspective, being so offended by the war on drugs, trying to find ways to counteract that using science. And through my work with medical cannabis, I got to one of the earlier psychedelic science conferences in 2011, ran into some colleagues there who were doing work on psychedelics. I was presenting cannabis research at the time, but I met Peter Hendricks, who some of you might be familiar with his work on criminal justice and psychedelics. And he was just doing a poster there, and we started chatting. And I realized that in some of my old data that I had from my dissertation looking at recidivism in jail inmates, we had substance use data. And some of his stuff was showing that people who would use psychedelics, even lifetime psychedelic use, were less likely to fail on probation. So as soon as I got home from that conference, I looked at my old data and found out we did have some information on psychedelic use in people that we had been following for recidivism. And so I did some analyses, and we found that the psychedelics were actually protective for people recidivating, particularly in domestic violence, which is an area that I was focused on. So that was how I got involved, first of all, on the psychedelic side of things, sort of transitioning from cannabis. And we published a couple papers looking at the protective effect of psychedelics for partner violence. And we were able to replicate it across a jail sample and across community samples. Sort of a long answer to how I got from being someone who was psychedelically informed in their personal life to realizing there was really this renaissance, a way to translate it into my professional life. And it's just really couldn't be happier to merge those two.
You're listening to The Psychedelic Report.
There was a lot of great anecdotal information out there and research being done and case reports being collected. Dr. James Fadiman, Sophia Kroerb, some stuff in Europe. And what they were collecting a lot of information on was around wellness and mood. And as a physician, I thought, well, that's all well and fine. And I also was at that time when I was seeing that is knowing that there was a lot of programmers in Silicon Valley that were also microdosing and hearing a lot of stories around that. So I kind of looked at that and I thought, well, that's great. But as a physician, I really wanted to know a lot more about what was clinically meaningful and, stuff on mood and on neuropathology and what could we actually improve. So Quantified Citizen had one study going on. I saw that. So reached out to Eastmeal, Santos Sprout, and Kaylin Harvey, who had that, and said, hey, could we do something a lot bigger that really pulled in all the validated studies, any validated study that we could put on an app and see what we can find out so that people like me, physicians, would know what might be clinically beneficial for our patients. And then we got Zach pulled in and he brought it to a higher level, and that's where we got to. So I'll hand that to Zach if you want to add more to that.
From working in medical cannabis, what I really learned was to follow the patients. in these areas where we have medicines that have been out in the public domain for a while, but have, not been the subject of strict study, which is kind of the opposite. We're going from the community into the lab as opposed from the lab into the clinic. So I think it's so important that we follow what patients are doing because there's a lot that can be learned there. Started working with East and Pam and Paul and seeing the potential reach that we could have for people who were microdosing in the community, an opportunity to gather as much information as we could from a large cross-section of microdosers. Just as a scientist was such a terrific opportunity. And I was just super glad to be able to get involved and add what I know about collecting survey data in a way that can inform policy and practice. So it was a great fit and a really fun ride so far.
Jump onto that a bit too, is these medicines, unlike any other medicines, are in use all over the place. And it's unlike the pharmaceuticals. And so having to go through those clinical trials is really challenging and really important. But if we could get this big prospective observational data coming forward, it would really give us a lot of guidance on where we should be going and what we should be studying. And unlike a pharmaceutical trials, like I said, these substances are already so easy for people to access. And like Zach said, you follow the patients. People are already doing this. So why not learn from people who are already doing this? And we were able to put that into a really robust format and take it through IRB and then launch it.
I love the way you describe that, both, following the patients, because people often know what makes them feel better. And this is a perfect example, cannabis research, being another perfect example of an opportunity to look at what people are using in the real world and track outcomes and see what's actually happening and try to quantify that in some capacity. It's an incredible vision. And it's something that I think heralds in a lot of ways the future of what more clinical trials could be like, especially to test things with people in the real world, the way they actually use them rather than the way they're told to use them, which poses a lot of questions in and of itself. And I'm wondering, when we think about this kind of study with, I think you have 13,000 people enrolled now, it's a huge thing that you guys have embarked on. And being someone who also runs a lot of clinical trials, and I do a lot of remote trials as well, it's pretty complicated to get one of these things going. And I'm wondering, could you talk a little bit about sort of the process of how you framed this for an institutional review board and IRB to be comfortable with approving it? And then also talk about what is the process by which people can get involved in the study to contribute information?
I can maybe talk a little bit about the REB, and we'd been working in dispensaries that were before legalization, so they were in a semi-legal framework, although some might say it was an illegal framework, and recognizing that there's things that people are doing anyways. And then the question becomes, since people are doing them anyways, can we learn from it or do we have to ignore it? And I think when you frame it that way, it becomes hard for ethics boards or for ethical researchers in general to say, no, you shouldn't do that. You can't use that information. And we have to be very careful not to guide and not to promote. Say, if you're doing this anyways, help us understand why and how you're doing it. And what can we learn from that? So I think the real sticking point for ethics boards or for conducting this kind of research is that you do keep it to that observational frame. And certainly there's been people who have contacted me from the study saying, what do you recommend? We really don't know. That's why we're doing the research. So it's humbling in a way as a researcher because you're not directing. Whereas in a clinical trial, as I'm sure you know, Dr. Dave, you're doing tons of directing people and telling them not this and not that and excluding and all that kind of micromanaging of participants. It's humbling, but it's also liberating just to let people do what they're doing and use the skills that we have. How can we reduce that data in a way that we can communicate it clearly to others?
I was just going to add that just another part of the answer of what Dr. Dave asked is how did we decide what to put in here too was we wanted to do validated measures. So the mood validated measures, like the PHQ-9, the DAS, PNAS, and then also anything that we reached out to our neurology colleagues and asked them, what do you do in the office that we could put on the app? And so that was really interesting. And I think that made it easier too for the REB to say, oh yeah, these are what clinicians do, and now you're measuring them.
You're listening to the Psychedelic Report.
What are our findings? We ended up with a large number of people who were not microdosing in the study, which is really powerful because if we only have microdosers, we don't have a comparison. But we got several thousand people who are not microdosing. And that initial paper that's under review now just compared the microdosers to the non-microdosers. what it showed is the microdosers demonstrated, some mild increases in positive mood, decreases in negative mood, less anxiety. Those are some of the findings in terms of mental health from that first one. And then the other thing that we were really interested in is what are the practices? What are people doing in terms of, supplementing their microdoses with either stacking? And we saw that a large number of people, I think about a third of them who were microdosing psychedelics were not just using psilocybin and focusing primarily on psilocybin, but not using just psilocybin, but also stacking it with lion's mane and chocolate and a number of other things. So we got some nice descriptive data on what's going on because there's such a diversity. When you talk about microdosing, it means different things to different people. And then in our second study, which has a slightly smaller sample, or actually a pretty dramatically smaller sample, but still stuck with us for a month, similar, but also real interesting results in that, there was a reduction across time in depression that was more pronounced depression and anxiety, microdosing versus the non. So psilocybin seemed over a course of a month to show reduced levels of depression and anxiety compared to controls. So even though it's not a controlled trial, we were able to have that control group and a within subject design so we could follow people.
Yeah, so we had a lot of case reports building on some of what Zach said. Like I've been collecting case reports on this for a long time. And we had a lot of case reports that were, saying, this helped my vision, this helped my hearing, this helped my balance, et cetera, et cetera. And one of the ones that we looked at was reaction time and the TAP test that we do with our Parkinson's patients and our Alzheimer's patients. And we saw some quite remarkable findings there that people that were younger seemed to just be pretty fast already, but we definitely see some very promising results in the over 55 group. And we have a sizable over 55 group in the microdosing study. So we're seeing that there seems to be quite a significant improvement in reaction time with the TAP test in the data. But we ran it through a lot of stats to make sure it was so promising. And that's really the benefit of these kind of studies, right? You get to have such a huge population that you can find these types of findings in there. And it's pretty exciting because if this turns out to be real, the unmet needs in medicine are enormous when it comes to these neurodegenerative situations around Parkinson's disease or Alzheimer's or ataxia. In fact, I've got a huge group of people that have ataxia, cerebellar ataxias that are getting remarkable results with the microdosing protocols.
One of these challenges that we come across in some of these real world studies that is an interesting challenge to navigate is people in the real world who might be microdosing or not are doing a lot of other things in their lives as well. There's so much else going on because all of us have full lives where we're doing tons of stuff. Some of it contributes to our health. Some of it takes away from our overall health. But, everybody has their own things that they do. And so how do you explain to people, or how would you explain to people when you're looking at the results that come back from microdosers using one protocol A versus B versus non-microdosers, that the results you're seeing as in the microdosers are actually indeed significantly related to the fact that they are microdosing versus other things that they could be doing in their lives?
Based on our findings, you're totally right. I mean, if someone is microdosing, in particular, if they're stacking and if they have a regular regimen that they're following, it probably means that there's a lot of other parts of their lives that are sort of well organized and that they're motivated. That suggests a pretty high level of functioning in and of itself. And that's not something I think you can control for. I mean, if you can do some statistical tests and we had control variables to try to make that equivalent. But one good thing about our sample, I think, is that the non-microdosers that we're comparing it to are recruited from the same place. So they're similar in a lot of ways to the microdosers. Many people who are microdosing are probably also using cannabis, and cannabis can have positive effects on mood, some of the other diminished anxiety. But with this study, our controls were also using cannabis, and we're also interested in maybe some of the same lifestyle interventions, mindfulness, exercise. So we don't have equivalents across all of those, but our control group is pretty good. It's not like we're just taking a cross section of the population that's dissimilar in many ways. They're pretty comparable to the microdosers. So you're right. It could be part of a bigger picture. And I think that's true with health research more generally. Just a lot of the time we don't want to say it, but health is overdetermined. There's so many factors and it's hard to say chicken or egg. The short answer is that control group does give us some confidence.
The challenge here is 99% of people are microdosing with what they get themselves in the underground. So they're microdosing with mushrooms or using the whole mushroom. And then those of us that are writing clinical trials are in a box of having to use lab synthesized psilocybin. And so it's not the same thing, really. I mean, some of the constituents are the same, but a mushroom has many more constituents than just psilocybin. You know, it has norpsilocin, baeocystin, norbaeocystin, and many other things. And so what's really interesting about this style of research is that we're actually studying in not the cleanest way, but in a very big way, what people are actually doing and what results they're actually getting. And then the challenge is then to bring that into the lab to see if what we're seeing in a big observational trial like this then is replicated in a more tightly controlled clinical trial. And then the challenge of doing that clinical trial is, when are we going to actually study what people are actually doing? The whole psilocybin mushroom. And that's the challenge for our regulators, Health Canada and the FDA, is how do they get to the place where they can help us researchers actually study what people are really doing? And then we'll actually be able to answer the question you're asking. Are the results that we're getting real? And the whole purpose of a large-scale prospective observational trial like this is, first off, to see, is there a signal? Is there something there? And then let's do a higher quality trial and bring it forward. And I think what we all want to get to in psychedelics, whether it's we use psychedelics for artistry and personal wellness, or if we're using it for a clinical reason, is what medicine, at what dose, at what interval. It's really a long path forward, but we're hoping that what we're collecting here in the Microdose.me trial is going to answer some of those questions and at least lead us into some really high quality research going forward.
Totally. I agree with everything that Pam said. From a research perspective, it's always a question of power versus control. And when I say power, I don't mean power over, I mean sort of power with. But the more power that you get is the more number of observations. And it's always a trade-off, because the more people that you're watching, you get a stronger signal, but you maybe get more noise. And certainly there's going to be some noise in this study in terms of maybe some people are not taking an optimal dose, or maybe there's even perhaps contamination, or people think they're using psilocybin and they're not. The hope is, though, with thousands of people in the study, that the signal from those, that most are doing it right, and that the signal from those is strong enough. I think we need both, right? We need those tightly controlled studies so we can really refine it. But I think we also need these large studies so we can start to see, you know, maybe some of the outliers. Maybe there's some groups for whom it's not effective, and we wouldn't see that in a clinical trial. Even though you might have more control, we just might not have representation from those groups. And there's questions about who gets into clinical trials and how do they get in? Whereas lowering that barrier for this kind of research, I think it allows us to invite more people into the research and have more voices in our data set, which is super valuable. I think when we talk about that difference between the corporate interests and people producing their own, I make my own kombucha. The rest of my family won't touch it because they don't trust it. I'm also allowed to ski, and that's dangerous. No one forced me to take lessons. So I think that the liberty, when we're dealing with something that's not terribly dangerous, and I don't think that there's good evidence of poisoning themselves with their own psilocybin mushrooms. So certainly it wouldn't be much of a victory if we have that corporate interest in a way that limits people's ability to do what they want.
You're listening to The Psychedelic Report.
And the other thing that I think is really important, and especially if there's people here that are watching that are doing clinical trials, or any regulators, is, we're really trying to fit researching this medicine in a way that doesn't really fit with the models we have out there. We have a pharmaceutical model for the gold standard that is for a single molecule. And the reality is these are not single molecules. I think we're at a phase here where we can be a lot smarter. We can put our heads together and go, how can we actually do pragmatic trials that actually study what people are actually doing and not exclude people? When I look at the exclusion and inclusion criteria for the trials I'm working on right now, it's not my patients. They're not. My patients would be excluded because they have too many comorbidities. And that doesn't help me as a clinician be a better clinician if none of the research pertains to my patient. We need the regulators to help us with this. Like, we're on this planet together. We're working together, not against each other. So tell us, how can we do real trials that enroll real people and still take care of patient safety and get out of the one molecule model? It has served us well. I have no complaints about it, but it is really not the way to move forward. Doing the quality, if we really truly care about patient safety, and about the quality of life of our patients, then we really need to work together to find a better model to study these medicines.
It's a great point. And another thing with doing research with these medicines that are already out there in the public, and I was the led a clinical trial of cannabis for PTSD, and we had a heck of a time recruiting people in BC. So you're looking then at asking people to perhaps risk being put in a placebo arm when they could have access to an effective medicine. But if you can go online or grow your own, there's a lot of reason not to risk being in the placebo arm, and maybe you're already using it.
Yeah, you're absolutely right. And I was just talking to Jim Fadiman yesterday, who I believe is here with us today, about this exact issue of this sort of dogmatic relationship to the single molecule paradigm and how that really doesn't leave a lot of room for the understanding of whole plant medicine, really testing whole plant medicine and the effect of it in the wild, the way people actually use it. And I couldn't agree more about what you were saying, Pam, about, how a lot of our patients would be excluded from the trials we conduct when they're conducted under the FDA guidelines or, under the standard inclusion-exclusion criteria that the FDA and the NIH likes to see, or Health Canada probably similar, because they are so focused on single diagnostic groups that fall under one or two categories of diagnoses, where you're really have an idea and of proposing the exact mechanism for the thing you're testing and how it works. And it leaves a huge gap. I feel like in a lot of ways you guys are doing with the observational approach first, which is we have this thing. We know there's a lot of variability around how people are using it. Maybe there's a couple different things that people are using. Let's just recruit in numbers and see what the numbers tell us based on what people are willing to contribute from their own lives. And the idea of being able to democratize research to the general community is so powerful, because I think a lot of people feel and have felt for a long time very disconnected from the research and the scientific process, where, most of the drugs that we use, most people don't realize almost all of the drugs we use in Western culture were actually in the trials tested on drug naive human beings. How many people in third world countries, how many of us are drug naive before we take another drug, right? Almost none of us. Almost all of us use either multiple supplements or medicines at the same time. We drink alcohol. People smoke cigarettes. They smoke cannabis or use cannabis products. There's people they microdose, they stack, right? There's all of these different things people are doing that is completely missed in the clinical trials that are done according to the traditional, very siloed kind of rigorous approach, which I think in some ways explains why a lot of the findings that come out of these single molecule drug studies in drug naive populations are actually not recapitulated. They're not seen in the real world. In fact, the results that are seen in the real world are often very different from what comes out of these trials. And I think that's an incredible strength with what you guys are doing. And it's exciting to see the preliminary results that you have so far and where this is going to go. I was wondering, could you talk a little bit about, just from the standpoint of how you've kind of opened this study up to so many different kinds of people?
Dave, when we talk about safety, sometimes an over-reliance on clinical trials can cause us to abandon our common sense and what we know. The opioids that have caused so much trouble and so much, heartache over the last number of years, those all went through clinical trials and were deemed safe. And everyone said, hey, it's, the drug manufacturers are able to say, hey, in clinical trials, these are safe. And we abandoned our common sense to say, well, you can't take lots of opioids over a long time and have that be entirely safe. You're going to develop some dependence. But
Absolutely
because
right.
Safety was defined as what happens in a clinical trial, they were quote unquote safe. And now with psilocybin and things like that, which we know are quite safe, we've seen people using them for a long time, for millennia. So we have a good sense of the safety. But at the same time, the criticism is we don't know about the safety because they haven't gone through clinical trials. We have to be real about what we're talking about when we talk about safety as well. I just wanted to add that in there and pass it to Pam to answer your question.
What I think is really exciting about this is it kind of returns science back to people again and says we are all scientists. We are all observational scientists. And what's really exciting about what we've done here is people are coming forward and say, hey, what about this? Would you measure this? Would you measure that? Or did you think about this? So we're designing our version 2. And we have so much more. And one of the big challenges with these medicines for us clinicians, physicians, and nurse practitioners and nurses, et cetera, is interactions. How do we get that data? How do we find out how these medicines interact with a lot of other medications or supplements or whatever people are doing? And so there's a lot of robustness here on what we can look at and hopefully fill in some of those blanks on that. So, and you asked about recruiting. We put it out widely through the microdosing communities. Paul Stamets was able to launch it, announce it on Joe Rogan. So that's probably why that's obviously why we have a skewed population to psilocybin microdosing.
And are these microdosing protocols, are they free-form protocols that people do on their own, or do you have some specific protocols that people can follow when they participate in the study, or that you ask them if they're following?
We just ask them. It is a prospective observational trial. We just ask people what they are microdosing. So when they come into the app, they're asked what they're microdosing, and there's the option for filling in anything we're missing. And then we follow what their regime is, what their dose is, what their structure is, how often they're microdosing. So it's really actually filling in a lot of that information. As the clinical trials go forward, people are asking, well, what is a microdose? What is that range? And so hopefully we'll be able to define what is that range and what is a microdosing schedule. I mean, there's not been a trial that's actually studied what is the optimal dosing, what is the optimal schedule. So there's a lot of information to get here, and we're hoping to provide some guidance, and then the clinical trials will take off from that.
You're listening to The Psychedelic Report. It's a very exciting opportunity to understand this better, because this is, as we said when we kicked off this show with you guys, this is one of the first times that we have actually been able to evaluate and observe the kinds of phenomena in the world that we are observing. And it is very, very exciting what you guys are doing. And I think looking at these observational studies in large scale in the population is an amazing first step to understanding these patterns of behavior, how using these medicines differently changes people's lives, impact of the patterns of use themselves and what people are using. And then also downstream, starting to look at the different protocols, like, is it the Fadiman protocol or the Stamets protocol that's making the biggest difference? And for which kinds of symptoms or which kinds of experiences are these helping out with the most? And again, of course, it's observational, so this is just correlative. At the same time, it's fascinating because using techniques like what you're doing and what, Ismail is doing with Quantified Citizen, there's all these really incredible opportunities to really survey a much larger group of people and understand what's going on in the community. So thank you for doing this work. We are very appreciative, and it's a very exciting time for psychedelic research at large.
We're happy to collaborate. If there's questions that need to be asked and should be asked, we're happy to collaborate on this. We really do want to get as much data out there so that really good research can springboard from this.
Then that's one of the great things about a study like this, is that it can be iterative and it can be responsive to the participants.
And Pam and Zach, do you want to have the last word to let everybody know where they can find you?
Hopefully you'll find me in a kayak with the whales. That would be my hope.
That's a good one. That's a great spot.
You can certainly find me on the website. Our lab has got a webpage, and hopefully you can also find me on a kayak, or a lot of the time you find me on a Zoom meeting with Pam.
That's right. You can find us at microdose.me.
Check out microdose.me. And I just wanted to express our great appreciation for all of the hard work you're doing in the field and all of the exciting preliminary results that you were able to share with us here today. And really appreciate your taking the time to join us.
Thanks. Thanks for having us. It's an honor to be here with you. And I feel like it's really a privilege to live in these times where we're moving out of prohibition and we can move into honoring, the indigenous traditions that got us here, and then also figure out what we need for our society so that we can move better, much more joyfully.
Glad to be here. And I just feel so fortunate to be able to work in this field and working on these questions. That's really enlivened me. And thanks for having me anytime.
Thanks for listening to The Psychedelic Report. Visit us at thepsychedelicreport.com. This show is recorded weekly on Clubhouse with a live audience. The Psychedelic Report was brought to you by Apollo Neuroscience and produced by Future Medicine Media. While I am a doctor, I'm not your doctor. So please don't take anything you hear on the Psychedelic Report as personal medical advice, because we don't know you. If you have questions about anything you hear on this show, please consult with your doctor.